Good morning and welcome to COVID-19 Talk with Local Health Authorities. Joining me is Dr. Janita White, representing Harris County, Dr. David Persh, representing the City of Houston. Special thanks to past President Kathy Finninger, Rotary Club of Houston, who provides these questions, and our producer, Morgan Ash. I'm Stephen Williams, the Director of the Houston Health Department. A lot of things are happening with COVID, and of course, our first question is related to vaccines. This week, vaccine advisors to U.S. FDA voted to recommend Pfizer's vaccine to 5 to 11-year-olds at 1/3 adult dose. How long for the FDA to approve? It's actually
I can start. I know the FDA is likely to issue their emergency use, probably not fully approved, but the emergency use in about a week. They've, following prior COVID-19 recommendations from the advisory committee, that the full approval basically requires additional months of safety and efficacy data.
Anything to add, David?
No, just that, after the FDA gets done, then the CDC, and one thing that people forget, although it usually doesn't matter, is that after the federal government gets done, the recommendations go to the states, and the states can then, they have the right to change the recommendations a little bit as well. That rarely happens, but there's multiple, and one thing is that there's multiple levels, so people need to feel assured that by the time it hits the street, it has been well reviewed.
Yes, I think I saw on the news this morning, I think I got it right, that the CDC ACEP committee is actually meeting sometime next week, so we'll see how that goes. Why are the vaccine doses based on age and not the size of the child? We have a pediatrician here, though.
So, excellent question. I know pharmaceutical companies usually choose age. It's easier to study. It would make it the ability to have the vaccine potentially out sooner. When you start using tailoring to your size of an individual, that takes a much longer type of study. So usually I think that's really why they do age invariably first. And if we look at previous vaccines that we currently have for children, if you look at the chart for kids, they're always usually given out by ages.
Of course, seatbelt goes by weight.
Yes.
I only know that because my wife told me that I didn't have to put my grandchild in a booster anymore, but I still do. I received the third shot and regret not having the mixed vaccines.
So, I wouldn't regret that too much. What we're finding is that, when you get the, with the mRNAs, the two of them seem to be pretty equivalent to each other. The only difference was that those who got the first shot of J&J that then got an mRNA seem to have a better response than if they got a second J&J shot. Although that second J&J shot is very good, but an mRNA following an original J&J seems to be the only one with any difference that's appreciable at all.
The CDC update says moderately or severely immunocompromised people may receive a booster 6 months after their third shot. When will we know if we should mix those vaccines? Is there any harm in getting too many vaccines?
So I know we did have recent guidance about mixing. I know this person's asking about severely immunocompromised people. So the recommendation is those individuals would stay with the mRNA if they've gotten the mRNA. Those who got the J&J, though, can mix. And so that's a more recent guidance that came out. The question about, is it harm to get too many vaccines? Really, we're still learning about, considerations for side effects. So to go beyond what's currently recommended would not be best practice at this time, because that kind of information is still being studied.
And we do have, nobody's going to study overdosing a patient on vaccines to see what happens. That study is not going to happen. So, but we do have anecdotal where people have gotten multiple doses, and most notably, and quite honestly, is when the financial incentives went out after the fact. We found that people used different names, they used different addresses, they did all kinds of goofy things to get extra doses. I've not heard of anyone having a bad outcome as a result of that. So, just at least anecdotally, we've not we've not heard of that. On the other hand, I would not recommend it. There's no need for it. Why risk you having an allergic reaction finally to something that you didn't need to?
And there's no added advantage.
There doesn't appear to be, yeah.
After having COVID and then being vaccinated, it sounds as if I am very protected. Can I still get the virus again? And if so, how severe might it be?
So I'll take that. And so the answer is unfortunately yes, you can. There is no 100% method to protection at 100% level. So we in the health department, we track a whole bunch of cases, and yeah, I mean, we know of cases of people who were infected, they got vaccinated, they got infected again, they got a booster, and then they still got infected. So the numbers, the percentages are really, really tiny. But to answer your question honestly, yeah, you can get infected still.
Is there any difference in susceptibility if you have COVID first and then get the vaccine, or the reverse?
So again, I don't think we've even seen studies that look at that head to head. Yeah.
If you take an antibody test and have low to none, should you get the full regimen of the 2 doses again, or perhaps another brand?
So I think we had this in another call that we really are not recommending sort of getting antibody tests to make a decision on whether or not you should actually be vaccinated. Now, there are probably some providers in unique settings, potentially maybe in cancer and oncology, that are looking at that, but that's still sort of anecdotal and sort of a study metric, because we know with regards to how you mount a response, it's not just what your antibodies level look like. It's memory cells and T cells that's not going to be captured in an antibody test. So if this is a unique question from an individual that may have other health considerations, or is thinking about doing a study, really that's really where that sort of sits with looking at antibodies.
Yeah. The only thing that I can think of that would contribute to this is that in England for a while, and they may still be doing it, for people who were documented previously infected, they were giving them a single shot of vaccine, getting their levels up. But that's because in England, they were trying to take the entire supply of vaccine and try to get it into as many residents as they possibly could. So they were purposely only giving them 1 shot instead of the normal 2 dose regimen. So don't confuse what you're hearing out of England. That was a public health policy decision to try and stretch their vaccine supplies as wide as they could. So here in the United States, where vaccine is ample, certainly if you got low levels, I would go with the full regimen. I wouldn't even consider just going with 1 if it was me.
Mm-hmm.
What is the status so far of breakthrough cases after the 3rd shot?
Too new to, we just start getting there. Yeah, I think it's too soon to say, because remember the 3rd shot for people who are immunocompromised, that's a whole different, that's not what we're talking about when we say the full boosters, right? So that 3rd shot, really, we're just starting to see those individuals, so more to come.
The WHO said anyone over 60 can receive a 3rd dose. When will the age be lowered to cover everyone?
Yeah, so that's a good question. It's a bureaucratic question. So the FDA responds to what the manufacturers submit, and they've submitted data looking at 65 and over. So I don't anticipate that age being changed in the United States for quite some time. There would need to be a deliberate action at the bureaucratic level to do that.
And then more recently, Dr. Peirce, to your point, the CDC did, Dr. Walensky, right, changed it from 18 and up. And then she said those can be for unique individuals who are nursing home attendants. They have other medical conditions. So it is lower than 60 in certain settings.
Sure.
Yeah, it seems like that. I call it the 4th bullet, was a catch-all for people who thought that they were at risk. It seemed to just be lenient. I'm troubled by doctors and nurses who refuse to be vaccinated, even if it means job loss. Do they have an inside scoop? No. Go ahead.
I was going to say no. And we know those, really, there's a lot of noise about those individuals. The other noise is that there's so many more healthcare providers who have gotten vaccinated. It is the majority that are believing that it's important to be vaccinated. It's a very small few who have made different decisions for whatever their considerations. And we know that again, going back to unvaccinated individuals are more likely to be at risk of getting infected, severe disease, illness, and then unfortunately having outcomes as poor as death. So You know, they don't have it. They don't have an inside scoop. It's just kind of their personal decision at this point.
There is no such thing as an inside scoop anymore, anyways. It gets out there in a minute, so.
No secrets.
Yeah. Unfortunately, so does the baloney, but you know, yeah, if there was a true, honest inside scoop, it wouldn't be an inside scoop.
That's true. Nobody's holding back on anything. Is there enough to cover all who are eligible to receive the initial dose plus third?
Yeah.
Yeah.
Yeah. There's plenty of vaccine in the United States.
Yeah, I think Pfizer is planning to have almost like pushing out at least like 4 billion doses. They're working very diligently to get more doses out.
Dr. Hotez said, I believe we can halt COVID-19 transmission in the U.S. if we accept that full vaccination means 3 doses of mRNA or 2 J&J, and we reach 85 to 90% vaccine coverage, meaning adults and adolescents.
Yeah, that's why we don't see measles anymore. That's why we're not seeing mumps anymore. That's why we don't see polio. Vaccines, when a whole population gets vaccinated, it works. So here in the United States, we do every year, not every year, but we do not infrequently. There's a small measles outbreak in New York City in a community that for their religious reasons, they do not get measles vaccines. And every year somebody in that community goes to Europe, which still has lots of measles, and they bring it back, and then they have an outbreak in that community again. But the rest of the United States, it doesn't happen. The virus can't get any traction, it doesn't go.
Do you think we're going to get there?
Not now. Not with. I'm the cynic in me. Is there's just the anti-vax movement, and the people with the who have mixed. There's 2 things that are being talked about, and they're getting mixed, unfortunately. One is the vaccine safe and effective? Absolutely yes. And then there's you can't tell me what to do thing. Okay, fine, I can't tell you what to do. So still do the right thing. But they're saying I demonstrate my not being told what to do by not getting vaccinated. And so it's tragic that these have gotten blended. But as long as those are blended, we're going to have a herd immunity challenge.
Now, I'm not going to let you get off the hook.
Oh, me?
You're the only other doctor.
I am way more encouraged, and will support Dr. Purse in keeping him, more optimistic. So I'll be on the more encouraging side.
As I look at the vaccination rates and I see it going up 1 percentage point, and usually the first thing you read on the reports is the number of people that have had their first vaccination. Sometimes I use that as a bellwether as to where I think we're going to land. And right now it's above 70%, isn't it?
Mm-hmm. And I think what we're hearing from people too, and Dr. Purse, again, you're frontline out talking to people, healthcare providers, people who are emergency personnel, and family and loved ones, right? And people are still wanting more information. So I'm happy about that they're asking, questions, and they want to know for themselves. So I do feel encouraged because people are still engaged in asking information, wanting information, that lets me know that they still are considering whatever they have on the fence, is they're still asking us those questions privately in our offices, privately at the dinner table when we go out. So I think I'm encouraged because the conversation is still happening.
All right, let me try and salvage my reputation just a little bit here and say,
hey, I'll give you a shot, but it's too late.
No. So the question was, are we going to get 85 to 90% vaccine coverage? And I don't know that. Are we going to get herd immunity? Because then you also factor in natural immunity from a lot of illness, maybe. But the problem with that is there's so much collateral damage that occurs. So anyways.
I'm hopeful, but I'm keeping my fingers crossed. What is the thought about amount of protection after having COVID versus getting the vaccine and then having the virus? Is age a factor? Aren't we seeing that? I need to read the question again.
Yeah, can you say that again?
I'm reading it just as it is, though. What is the thought about, the amount of protection after having COVID versus getting the vaccine and then having had the virus? Is age a factor?
Okay, so The way I hear that is they had COVID, and then the question is, should they get vaccinated? And certainly they should after their quarantine time and all that. They should still get the vaccine series. And, one of the challenges is, how much protection you have. When you say someone's 60, I mean, they may have multiple medical conditions that make it where they just didn't mount a strong enough response, which is why we say, even if you've gotten the infection, please get the vaccination series. So that may be what they're asking.
Okay.
Let me give a nerd answer to that, because there are a couple of studies looking at the first part of this question. And if you got natural infection, most of the studies were showing that the level of antibody production was really quite variable from one person to the next. It was not consistent, and its durability was a little bit in question as well. And that's what we have been going. Then a study came out of Israel by a very reputable group that did a very well-designed but relatively small study. And it actually was the only one, but it was a well-designed study, showed that natural infection gave actually pretty decent immunity. So it's a mixed answer, because we got some data suggesting natural immunity isn't terribly robust, and we've got one decent study showing that it may be. So we don't know. And I would not count on natural immunity at this point. I would still get vaccinated.
And to your point, Dr. Purse, I wonder if that question also was, I don't remember Israel, was that before the Delta variant?
So good question. I don't remember the answer to that. I don't remember when it was. Yeah.
Any anecdotal information on healthcare workers transmitting to patients?
So
not recently.
Anecdotally, I mean, healthcare workers are usually well PPE. They're wearing protective materials. So I've not heard of that going that direction.
Okay, this is on reporting. Please comment on the city-county dashboard. The percent of cases by age with the highest numbers is 30 to 39, followed by 60 to 69, and 0 to 9. Is there any reason for?
So one consideration when you think of the 30 to 39 and behavior, I mean, that was not a group that was first encouraged for vaccines right when we did vaccine rollout. So the vaccine rollout to that group came, and then right behind it, the Delta variant. And that was a population that behavior mattered. Were you doing the mitigations that we were asking? So there is a consideration that those individuals not only got infected, but they actually got Delta variants. And I don't know, Dr. Purse, I mean, the 60 group, they may have been vaccinated. They had that sort of durability. They were waning right around the time that the Delta variant. So for that group who did everything they needed to do, vaccinated, Delta variant came. And so they were just more at risk because of the Delta variant. And in that younger group, I mean, they haven't had a chance to get vaccinated. So that was all the reasons we did in the front end of everybody get vaccinated to protect the younger population who couldn't get vaccinated. That's how I would think about those sets of groups.
Yeah. So when I just happened to look at our data last night, and off the top of my head, I don't know if it's exactly the same, but yeah, the 30 to 39-year-old group seems to have the highest number of new cases. But it's kind of a bell-shaped curve with the 30 to 39 peak, and so there may be the 60 to 69 may have been more than the 50 to 59, but it wasn't a lot. It is pretty much a bell-shaped curve, but peaking in that age group because of, I think, two things: one, low vaccination rate, and they're highly mobile, getting in and out around the community a whole lot. And so
the percent of weekly total cases by race ethnicity shows whites up, Hispanics down, with Hispanics testing up and white testing down. Your thoughts?
So with testing, here's one thing: with testing overall being really low like it is now, it makes it really hard to interpret the data because your denominator is so small. Yeah, I mean, I think that, we still report the positivity rates. We're still glad to see that they're going down. But when you start, slicing and dicing based on race and ethnicity, the numbers get even smaller. And I'm not sure that I would try to interpret that very much at all at this point.
Long haul. The common reframe is, if you've had COVID and the vaccine, you have superpowers. What about long haul? Should I get a third vaccine if I currently have long haul?
So if they're asking third dose to help mitigate their symptoms of long haul, that's not been anything proven, and that is not data for that. It's not intended for that. But certainly, I think this came up again in one of our calls, that the TMC does have some resources for the long haul COVID clinics. And that individual really should look into being a part of those clinics because they want to look at what these individuals are experiencing and give them a little bit more guidance on long term.
Is brain fog worse for those without vaccinations?
You know, I don't know, but as Dr. White just pointed out, we do now have multiple clinics in the TMC with each of the major hospital chains that have people who are gaining expertise in that. So if you're dealing with brain fog, I would get myself into one of those clinics right away.
And I know we really don't hear vaccinated individuals with symptoms kind of mention brain fog. It's those unvaccinated individuals who are sick. Then they discuss that their long symptom is feeling that fogginess. And again, I think those centers are going to start teasing that information out over time.
That underscores, I think, the advice you're giving to have that person try to participate in those clinics.
Yes.
Definition setting. Dr. Fauci said the third mRNA immunization may slow or halt vaccine shedding. A school in Miami that claimed vaccine shedding of spike protein was just stopped by their Department of Education from forcing vaccinated students to stay home for 30 days after each shot. Haven't heard if they were successful in keeping vaccinated teachers out of the classroom, as they have announced. Please shed some light on the subject and clarify for the public.
I mean, I guess my thought is, misinformation. And so the Fauci comment about shedding is when you have natural infection. So vaccination doesn't give you the shedding. So it's a misinformation if the narrative is vaccination causes shedding. It's natural infection that has you at a risk for shedding. And that's what Fauci was mentioning.
Okay. What is the anti-genetic shift and drift?
So we see it's not antigenic, it's genetic shift or drift, and it's the genome of the virus. So the best example is the flu virus has drift every year, which means it moves a little. So that's why every year we get a different flu vaccine, because the flu virus circulates in the northern hemisphere during our winter. It then migrates south for the winter. Basically, humans bring it south, and then in the winter months in the southern hemisphere, people get it. But it changes a little bit. Every time somebody gets infected, there's a chance for a mutation, and that's what happens. And so when it comes back up north again, we have to get a slightly different vaccine than the year before because it changes a little bit. Genetic shift, as opposed to drift, is when it changes a whole lot. So when we get a big change, so the coronavirus, the coronaviruses had existed. So SARS-CoV-2, there's a lot of argument about where it came from. That is an example of what was some coronavirus originally changed a whole bunch, and now we got a whole new problem. So that is genetic shift versus drift.
Flu season will be bad this year because we missed last year.
I think we don't know. I think we don't know, but we actually, let's think about what we've seen so far. So we're encouraging people, get your flu vaccine early. They are available now. Hand washing, masking, watching where you are with environment. And if you have symptoms, please don't start getting around other individuals while you may have symptoms. So
IHME said we will be living with this virus a long time.
Yeah, I would agree with that. I think that unfortunately, globally, we have we're seeing that a new variant pops up and you pick a country, and within a week or so, we're able to find it here in the United States, right? So we live in a world where, so long as on the planet we have vaccination challenges, we're going to be dealing with this virus for a long time. I think they're right.
COVID is the number one cause of death for 35 to 54-year-olds.
I don't know that that's accurate, is it?
We don't really know. NPR had a story about Sparrow, Michigan hospital, whose ICU is full of very ill non-COVID patients. Is that because people avoided hospitals for so long and are now much worse? How's Houston doing?
Yeah, I'll take that one. And the answer is we have seen that here in Houston. So looking at our EMS data, when COVID first hit, our EMS call volume, for example, dropped very, very low. The people were afraid to go to the hospitals. They were afraid to call 911. And then after that, and people were afraid to go to the hospitals because they were afraid they were going to catch it if they went to the hospital. They're afraid to go to their doctor's office. And then after that, we saw an increase of people who, and I can tell you from personally observing it, people who had been having chest pain for 3 or 4 weeks as they continually had small heart attacks, or their critical heart vessel lesion just continued to chip away more and more heart muscle, and then they were in congestive heart failure, completely avoidable. We're not seeing that today. Things have gotten much better, but Houston went through that phase, absolutely.
Rapid test shortage. Is it still true?
Monday, I think Monday Biden announced he's going to try to speed up authorization for at-home studies.
Okay.
And I think also working with FDA to kind of look at their processes.
Risk of neurologic complications was higher after SARS-CoV-2 infection than after the COVID-19 vaccination. An analysis of 32 million people in England showed. Are y'all familiar with the study?
I have not heard that.
Not that study, but I mean, back to our previous discussion, we know more about symptoms post-infection than individuals who are vaccinated and have, some outcomes that we report to VAERS and look at that. So worst complications when you get the natural infection.
India's Zy-COVID-D is the first clinical use of a DNA vaccine in humans. Please explain this, and what is the needle-free injector?
Well, I'm just not familiar enough on that.
Yeah, I'm not familiar with that big vaccine either. However, there are other vaccines that are out there, that are in common use that are DNA vaccines. So, I fear that this will, stir up all those comments about it changing your DNA and making horns grow out of your head and blah, blah, blah. But we've been using DNA-based vaccines for decades, and none of those crazy things have ever happened.
We're coming up on Halloween. Any safe Halloween tips for this year?
Wear a scary mask.
When I think of masks, I think about the masks that have their eyes and mouth actually cut out, and I don't think those are protective, are they, doctors?
No.
No, but we got really creative people out there. You could take a regular, COVID effective mask and decorate it up in all kinds of neat ways to make it scary and match the rest of your costume. And the other thing about Halloween is that the trick or treating is obviously generally an outdoor event, and so that's good, right? So if you're going to go with your kids and you go trick or treating in your neighborhood and you're doing it outdoors, and the kids are all wearing costumes that got masks, and the parents are wearing costumes that have masks too, then Halloween becomes probably the COVID perfect holiday. I don't know that I would want to be indoors in a crowded high school gymnasium with 400 kids and their parents and everybody dunking for apples and taking the masks off and coughing and choking on water and stuff. That one I probably wouldn't want to go to. But outdoors trick or treating, oh, bring it on.
Bring on outdoors trick or treating. I think that's a wrap. Thank you for joining us for COVID-19 Talk with Local Health Authorities. Dr. Janina White, representing Harris County, Dr. David Persh, representing the City of Houston. Thank you to past President Kathy Finninger, Rotary Club of Houston, who provides us with these questions, and our producer, Morgan Ash. I'm Stephen Williams, Director of the Houston Health Department.